Science is a newly formed trainee-led research collaborative that is dedicated to empowering future healthcare leaders across Southern Africa. So our aim is to unite medical students, interns, community service doctors, registrars, and early career researchers to conduct high-quality, impactful research that addresses pressing healthcare challenges that are relevant to Southern Africa. By working together, we contribute to scientific advancements and help shape the future of healthcare in our region. Just to let everybody know that we will be recording this webinar. And without further ado, I'll go ahead to introduce our panelists for the evening. So our first panelist is Prof. Bruce Biccard. He is a professor of anesthesia and perioperative medicine at the University of Cape Town and a specialist at Groote Schuur Hospital in South Africa. He is internationally recognized for his work in perioperative medicine, particularly in improving surgical outcomes in low and middle income countries. His research focuses on global surgical risk, perioperative care, and collaborative data-driven studies that aim to reduce mortality and complications after surgery. Prof. Biccard has led several large-scale, multi-center trials and is actively involved in international research networks, including the African Perioperative Research Group. He is passionate about advancing patient safety through evidence-based practice and international collaboration. Our next panelist, Dr. Zane Farina, is a consultant anesthetist and deputy head of the Clinical Department of Anesthesia at the University of KwaZulu-Natal, based at Gray's Hospital in Pietermaritzburg. He holds an MBCHB from the University of Cape Town, a diploma in anesthetics, and is a fellow of the College of Anesthetists of South Africa. Dr. Farina has been instrumental in enhancing medical infrastructure and fostering community among clinical staff, notably advocating for the development of a dedicated doctor's lounge at Gray's Hospital. His research interests encompass critical care medicine, sepsis, intensive care, airway management, mechanical ventilation, cardiopulmonary resuscitation, and pain management. Dr. Farina has contributed to various publications in these areas, reflecting his commitment to advancing anesthesia and critical care practices. Our next panelist, Dr. Zodumo Mvo, is a pediatric consultant at the University of KwaZulu-Natal, with over 10 years of clinical experience in child health and public health research. Her areas of interest are in bedside clinical teaching, evidence-based clinical care of children, and conducting public health research. Some of her previous research includes healthcare-seeking practices of pregnant women, maternal and child health, and HIV/AIDS cure research. An honorary attachment to the Julius Center for Epidemiological Research at Utrecht Medical Center in the Netherlands inspired a desire to tap into global health research, which is fast gaining momentum in South Africa. She holds an MBCHB degree from the University of KwaZulu-Natal, a bachelor's in social science honors degree in anthropology, and an MPhil in epidemiology and biostatistics from the University of Cape Town, as well as an FCP'd from the Colleges of Medicine, South Africa. She is passionate about mentoring and teaching, imparting clinical skills and evidence-based knowledge to students, research candidates, and junior staff in pediatrics and public health research. And finally, our final panelist, Dr. Shrikant Peters, is a dynamic medical professional from Pietermaritzburg, South Africa, with a strong foundation in public health and medical management. He completed his medical training in 2010 and has since held various roles in primary and district hospitals across Durban, Johannesburg, and Cape Town. Dr. Peters furthered his expertise by completing residency training, qualifying as a public health physician in 2019. He has served as the medical manager of perioperative care, critical care, and transplant services at Groote Schuur Hospital, and currently holds the position of Chief Clinical Information Officer at the same institution. Additionally, he is an honorary lecturer in public health medicine at the University of Cape Town. Dr. Peters is actively involved in advancing the professionalization of medical management in South Africa and beyond, contributing to the broader healthcare landscape. I'd just like to say thank you to all of our panelists for making the time to be here this evening. And I'll hand over to my co-host Z to give us a bit of background about what collaborative research is.
Thank you, Michelle. So before we get into the panel discussion, let's quickly talk about what is collaborative research. So it's a research approach where individuals or organizations work together to achieve a common research goal. It brings together diverse backgrounds, skills, and knowledge, leading to more comprehensive analysis and more innovative solutions. There's a few types of collaborative research. So we have team research, where researchers within a lab or a department work together on a project. There's interdisciplinary research, where researchers from different fields collaborate on a shared topic. Community-based research, where researchers partner with community members to address local issues. And also international research, where researchers from different countries collaborate on global challenges. And the benefits of collaborative research include shared resources, where we can pool funding, equipment, data to overcome limitations and accelerate progress. There's increased accuracy and validity by cross-checking findings and assessing different methods, and enhancing innovation with the exchange of ideas and perspectives. And this can spark new insights that lead to breakthroughs that might not even have been achieved by individual researchers. Before we get to the questions, just want to remind everyone that the chat function is available, and if you have any questions during the discussion, please feel free to add your questions, and we'll try and get through as many as we can at the end of the presentation.
Cool. Thank you for that, Z. So let's hop straight in. Our first question is for Prof. Biccard. And the question is, what makes the Southern African region a unique and critical hub for global clinical research? And what specific health challenges, for example, HIV, TB, non-communicable diseases, should be the highest priority for collaborative efforts right now?
Yeah, thanks very much, and thanks for the invitation to your meeting. I think the reality is that there are so many health challenges that we have in South Africa and Africa in general, that I think, there's opportunity for people really to work in any area that interests them. I think there's a lot of space for us to make a difference. The most important thing, though, I think, is to realize that the work has to be context sensitive. In other words, it's appropriate for the environment, and it should be based on locally set priorities. So my interest is surgery and the perioperative space. And so what we did when we created the African Perioperative Research Group was to set local priorities. So through a Delphi process, which is a mechanism of developing consensus, we came to agreement on the top 10 priorities for research on the biggest, what we believe were the most important perioperative problems that need to be addressed. And then we systematically started to address them. And I think that's what's really important. So, the people on this call today or on the webinar today will have different interests, and that's absolutely fine, and there's work to be done. And I think really what you have to do is you need to create groups of areas, say in medicine or surgery, psychiatry or whatever, and then agree as a community on what the priorities are. Once you've done that, then I think you'll know where to focus your efforts on from a research perspective.
Thanks, Prof, for that answer. I think that's really important that we highlight priorities so that we have the most impact with our research. Moving on to Dr. Farina. A common criticism is so-called helicopter research, where external partners collect data and leave with little long-term benefit for the host country. What practical mechanisms can we implement to ensure genuine co-ownership of the research agenda from grant writing to publication? And how do we move beyond the traditional North-South model to foster more equitable partnerships and encourage robust South-South collaborations within the African continent.
Thanks very much. Thanks for your generous introduction. My one comment to that introduction is don't believe everything that you read on the internet. So anyhow, that's fine. Yeah, I do have a lot of interests. Yeah, Prof. Biccard has actually answered some of the stuff about helicopter research, where he has spoken about developing a local group and local priorities. The big problem is people living in underdeveloped areas being seen as research subjects where ethical requirements are perhaps a little bit lower than they may be, and also cheaper to access than they may be in the Western world. And I think we have to push back very strongly and very vehemently against that. Having said that, if you push back too hard, then of course we lose opportunities. So one of the things to do the GCP courses. Make sure you've got one doing one which has got that little Africa focus, because that's one of the things that is done. The South African focus emphasizes the problems that occurred around the Steve Biko affair, and then also emphasizes the problem of helicopter research. So do that. And then also involve yourself. I think it's also going to later come up in the mentorship question, where when, for instance, you've got this brilliant idea and your international collaborator goes away with your idea and then comes back with a completed project without any interaction in between, I think that's a little bit of a red flag. Make sure that you are being involved in writing the proposal and checking out exactly what they're planning on doing. And equitable partnerships. So some of the partnerships that I'm currently involved in, for instance, a critical care one, where we are working on ARDS definitions from data that came mostly from our COVID period and so on. They treat us very respectfully. They're always involving us in webinars, asking what they can do. And they've certainly helped me a lot with learning how to clear up data and remove missing data. So I think it's in that partnership that the secret lies. I'm not sure if there's any other more specific things where people want to perhaps put problems that they've had in the chat and perhaps get some advice on how those problems might have been avoided. Thanks very much. I'll leave it there.
Thanks so much, Dr. Farina. I think that's a very important point, that for especially early career researchers and medical students, junior doctors, to make sure that the GCP qualification you hold has an African-centric focus so that we can move forward with those principles in research. Dr. Mvo, the process of obtaining informed consent can be quite complex, as we all know, especially across different cultural and linguistic contexts. What do you think are the best practices for ensuring true understanding and voluntary participation in research?
Good evening, everyone. Thanks for the invitation and for allowing me an opportunity to share. I'll take it that everyone knows the definition of informed consent. Or maybe I should just remind ourselves, because really when we're talking about different language groups and also different cultural groups, it takes us back to what do we understand about informed consent. So informed consent is defined as a decision to participate in research taken by a competent individual who has received the necessary information about the study that you're planning to conduct. So it requires adequate understanding of the information on the part of the research participant. It also requires them to arrive at that decision without coercion, without undue influence or inducement, and without intimidation. So that whole concept really revolves around ethics in conducting research. And when we're looking at the context of a clinical trial, this is a process by which a subject voluntarily confirms his willingness to participate in a particular trial after being informed of all the aspects of that trial. in which the subject has to make a decision to participate in. So as the previous speakers have already highlighted, that collaborative research in its own, it involves a high and low middle income countries. So there's already a dynamic, even before you go to the subjects, there's already a dynamic just between the research collaborators in terms of there's a power dynamic. So that power dynamic is actually aggravated in the researchers, in the research participants, because most of the field work tend to be done in low middle income countries, where we are confronted with these language issues and also cultural context. So in the area of language, we know that our research protocols are usually in English, and English is not the first language for most of our participants. And also we are also confronted by issues of education level, where most of the participants are uneducated or are illiterate. So to get around these issues, research ethics committees, they really monitor and guide the interest of the research participants. So what we can do as researchers in terms of the language context, because as we have seen in the definition of informed consent, there has to be an adequate understanding, of the actual research. So you need to explain the research protocol in plain language, even for the participants that are educated, because they may not be familiar with the discipline in which the research is being conducted. So, and we know that most research protocols, they use technical language, and even in describing the research method, it's language that even a highly educated professional would not be able to understand. So that is the one area to consider. And also, it's important to translate the protocol into the language of the research participants to ensure the accuracy of the protocol. And then besides translating it, you also have to back translate it to the original language. But this has to be done by a different translator, and the two versions need to be compared by the researcher for validity. We also have participants who are illiterate. So those participants will not be able to read the protocol itself. So in those cases, we get to read the protocol to them orally, or we can also use audio-visual explanations, drawings, or photos. We can also use dramatic presentations or video presentations of the research intervention. There is an example of an audiobook that was developed by VET, Bioethics Center, but it still needs to be validated to see if it does actually achieve what it's set to achieve, like to explain to the research participants in a way that would be effective for them to understand the research. When we're talking about cultural context, which is the last point, we know that bioethics itself as a discipline was not developed in Africa or Asia. It was developed in Europe and North America. So in recent development, this has actually led to criticism about its individualistic nature, that in most African countries and Asia and even Latin America, our research participants in those countries, they still rely on family and community in terms of decision making. So there are strategies that we have to consider as researchers to try and solve those problems, the cultural problems that arise in those countries. So the researchers should be free to adapt their consent requirements to local culture, but they have to do this in consultation with local research ethics committees and national research ethics committees. But there's also an alternative view which really promotes human rights. where we know that everyone has right to life, they have right to liberty and security of persons. Therefore, in some contexts where you find that family or community ends up having to make decisions for the individual, we have to actually quote that Universal Declaration of Human Rights, and there should not be any circumstance where an individual's informed consent is overridden by either family or community. But we know that in some rural communities, there could also be a need to consult a local chief or community leader. So we have to do our research even before we conduct the studies to actually find out and understand the communities in which we are planning to do the studies and observe the practices or what is expected of the researchers to gain entry to the community. I'll leave it at that for now.
Thank you, Dr. Mvo, for such an insightful answer. I think it's so important that, as you said, before you've even started collecting data or interacting with your participants, that you have a clear understanding of the cultural context, whatever existing power dynamics they may be, and be aware of the mechanisms to overcome these barriers so that our participants have their rights acknowledged and respected. Moving on to Dr. Shrikant Peters. So we've spoken quite a lot about language and cultural context, which could be possible barriers for research. What do you think are some other barriers to collaborative research in Africa that you have experienced? And what do you think can be done to overcome these barriers?
Hello, excuse me, was that question directed at me? Okay, can you please repeat the last part of the question?
I think it's Shrikant's question, isn't it?
Yes, yes. Oh, I see he's unable to unmute.
Yeah.
Let's just see what's going on here.
Great, thank you. Can you hear me now?
Yes. Sorry
Great.
about that. There we
Thanks,
go.
thanks very much. Sorry about
No
that. Thank you for the question. Was what are the barriers to collaborative research in Africa that you've experienced, and what can be done to overcome these barriers?
Yeah.
So, currently my role, and since finishing my time in public health, has been as a medical manager of a tertiary facility. Some large disciplines and areas of the hospital with large budgets. That being theatre and the emergency centres. So having world-class researchers in facilities, which we have in South Africa, is fantastic. We're able to punch above our weight, but really, it's the centres that generate research, which are generally high-functioning already, right? There is a bit of a selection bias in that. And it's unfortunate, but systems that are in crisis from day to day, they simply don't have the capacity to think beyond the here and now. And so if we're not fully budgeted, if we're not well resourced, if we have staff that are running helter-skelter just to provide basic clinical care, let alone excellence in clinical care, it becomes very difficult to then make the argument for further resources for research. Right? And that's unfortunately, that's self-fulfilling. If we focus on crisis management day to day, we never really have the opportunity to lift our heads from the current crisis and start asking ourselves, is what we're doing effective? Is it cost effective? Is it what patients want? Is it what's good for the country? And those are higher order questions that really can only come from clinicians when they are well capacitated to do their work, their primary work of service delivery. And then obviously focusing on governance and policy development and knowledge translation, all these good things that come with and come from research. Second, so that is very acutely felt in South Africa, and especially the last 2-3 years after COVID with the budget constraints that we've been hit. But speaking to colleagues in the rest of Africa in the management and public health spaces, it's a common problem because budget is constrained. And research really comes when you've got in excess capacity, both in terms of your budget and your staff availability. So second to that, we should also collectively determine what are our research priorities. We haven't, at a national level, determined what is our research priority, what are we going to spend money on, what are we going to give to HEIs to focus on. On the question about research and collaborative research in Africa, and I say this as a proud UCT graduate, our focus unfortunately has been on the US and Europe. And in terms of targeting, we do tie ourselves to best in practice globally. And you'll find those kinds of indicators and targets, both clinical and public health, in higher income countries. But what we need to do is facilitate greater links within the continent as opposed to transcontinental. Our research links tend to mirror our trade links. We've got more countries in Africa trading with the world rather than trading intra-Africa. And so with certain sort of research groups like the African Perioperative Research Group that Prof. Biccard heads, we've started to facilitate greater links with the continent. Other barriers, of course, we're underdeveloped in terms of our infrastructure, basic hardware and software, just Wi-Fi in hospitals. For some facilities, it's computers for collection, transmission, reporting of data. And then the last one I'll leave you with is just underdeveloped policy development on guidance of data sharing practices. Really what you'll find in Europe and the US that have these big national and supranational collaboratives with a sort of large databases, registries that support research. They started within higher education institutes as local registries that were then built into national registries and continental registries. So we really need to focus on policy and data sharing practices between governments and higher education institutions to build those together rather than adversarially. Thanks.
Thanks so much, Dr. Peters, for that answer. And I think that echoes what Prof. Biccard mentioned as well about really sitting down and highlighting what our research priorities should be for the most impact in our country. I am now going to hand over to my co-host Z to continue asking a few more questions before we turn to the audience.
Thanks, Michelle. Prof. Biccard, brain drain remains a significant challenge, and in this time it's come up again as a pertinent issue. How can collaborative projects be designed to actively mentor and retain sort of local and African scientists, clinicians, staff in research projects, and how can we create a clear pathway for them to advance their careers locally instead of thinking about moving abroad?
Thanks, Z. I think this is a super important question. I think there are two real issues here. And the first is that no one will be a better expert in our environment than the people who live and work in the environment. And so long as you're doing investigator-initiated and led research, which is context sensitive, I think it's very powerful. The second thing is we need to recognize researchers and investigators in our local environment. Certainly there's a massive opportunity for growth locally, both in South Africa and the broader African environment. And I think really what we need to do is we need to focus on our strengths, and then we need to provide support and mentorship in areas which are difficult. And so this is where the question about mentorship comes up. Mentorship is difficult. It requires work. It requires participation and patience. And so what one needs to do is have a clear agenda on the sort of skills that one wants to develop within a community of researchers within our own community. And so those individuals who have some of the skills need to be willing to share and educate. And so this can be done in small group tutorials, virtual tutorials across the continent that happen periodically. We've started trying to do some of this in the AppOrg network. We started with simple things like some biostatistics, allowing people who are interested in that to participate and grow their skills. And then at the same time, with successful research projects, one generates data. And for secondary papers and sub-analyses, it's a perfect opportunity for researchers who've been participating in the research to learn different skills, either to learn how to ask a question, learn how to answer it, learn how to write a paper, and, coupling up individuals with those who are skilled in each of those areas, but allowing the individual who wants to grow in that area to lead and then be mentored by the senior person, I think is very powerful. Again, we've started doing that in the AppOrg network. It does take time, but certainly I think for the broader research across Africa, it's going to be very powerful in time. I think what mentees need is they need a community of support. I think my best example that I'm aware of is actually in a clinical environment, but there's no reason why it can't be extrapolated to the research community. But Prof. Jan Fagan, who was head of ENT at UCT till recently, has done really well in creating a community of ENT surgeons across Africa. And one of the things that they do is they meet almost every week virtually. They discuss the problems they have, and as a team, they discuss the solutions. And I think that sort of model is super important for supporting young researchers, or not necessarily young, or researchers where there are skill sets missing. I think for all of us here, we've come from an environment which is very clinically orientated, which is good. And most of our research education is pretty informal. And so doing that, I think, is really good. And then the last thing is, I think, there's no problem bringing in experts, international experts from from say outside Africa, to help mentor and help train and educate us in areas where we do not have the skills. There's no problem with that. I said in the chat, I'll paste some of the reflexivity statement, but really you'll see in that statement that, no matter what happens in a relationship in research, if you're in the sort of our environment, in a sort of a low resource environment, what happens is you got to make sure, one, that the work you're doing is relevant, that you've initiated the work, that you own the work, and that anyone who contributes from the outside contributes in a way which is productive. In other words, it enables the work, it grows individuals within the network, etc. So I think there are quite a lot of things. This is a very important topic, but it does require effort.
Thank you, Prof.
Thanks.
Thanks for highlighting some of the challenges and sharing some ways that we can encourage and retain our own talent pool. Sort of on this topic, Dr. Farina, I want to ask you, what advice do you have for a mentee to make the most out of a mentorship opportunity, or even before that, how do you find a mentor and how do you make the most of that opportunity?
Sure. Yeah, I think probably that the second part of that question becomes more important because so much was covered with Prof. Biccard. I think finding a mentor, remember, first of all, I don't think there's such a thing as one mentor. There's got to be multiple. There's got to be a certain amount of insight. I want to do this thing. What do I research in this case? What do I lack? What skills am I not understanding? And for instance, statistics always comes up. Everybody hates statistics and fears statistics. We'll go and find somebody who really knows statistics. And for instance, that's not me. I can look at a paper and see whether it's statistically sound, but I'll confuse you completely if I try to explain to you. You rather need somebody who's got better explaining powers. And that means that you're going to need to find multiple people. That's my stats guy, and I've got a couple of stats people under my belt who I go and ask when I'm confused. Then you need you need experts in the field you're looking at. So obviously you can't come to me and ask me for help in surgery, but I can definitely tell you a thing or two about anesthetics and about what our challenges are and what are the unknown areas. And then I've got a passing interest in critical care, so I can help there as well. Other bit of advice is sort of to be open. I think we often have to try and break down the power relationships. You know, often people have got big titles, professor, head of department, and all that sort of thing. We're actually just human. We all run out of time and have difficulties. And sometimes if we might seem a little bit aloof, it might be just because there are other things on our mind at the time. One thing that I've picked up from Bruce, which I think is incredibly valuable, is send a little summary of what you thought the meeting was about. If you spoke to your mentor and you got this little bit of advice, and then that's how you thought it should be reflected, send a little note back. We met today. This is what I got. What it means is that if you've got confused or you've got the wrong end of the stick, the mentor's got a very quick chance he can pick it up and say, oh, I really didn't come across well there. And he can initiate an early contact to correct the misconception rather than it barreling on again through multiple visits. And I think that's probably enough in the answer to the question, and we'll see if anything more comes up in the chat. Thanks very much.
Thank you, Prof. Farina, for sharing some of the ways. Just want to maybe add on to that. Can I ask you, what's the best way to approach, do young researchers or young doctors in med school, they part of a tertiary institution, it might be easier, but if you're out internship or ComServe and you're not working in that environment, do you have any advice for people like that?
Yeah. So I think it probably differs from different people. If you really want to unnerve me, walk up to me, tell me how great I am, and then say, I want you to be my mentor. And, I'll be so flabbergasted. I won't want to do that. Some people, I think, might want to be approached like that. I'm much more just like being asked a question. So, for instance, I do a lot of support to district hospitals trying to help people get equipped for anesthetics. And a very comfortable approach, which I like, is I had this problem, Dr. Farina, how can you advise me? And I think some of my best relationships have developed from that, obviously helping with the acute advice, sorting out that immediate situation. And then also, if you approach someone and you don't click with them, don't worry about it. Find someone else, and certainly, not everybody who talks to a mentor becomes a mentee. Not every, and that's not. It doesn't say anything about either of the two people. It just hasn't clicked as a relationship, and just keep going, keep asking questions, make yourself open, and you'll find somebody who you do click with, and then just maximize on that relationship. I think it'll probably be quite useful to get some of the other panelists to say something about this, because I know that everybody will have a different approach to how the relationships start. Thanks very much.
Thank you, Prof. Farina. Does anyone of the panelists wants to add onto that?
Sorry, Z, I just put my thoughts down in a chat while Zane was talking.
I'll have a look.
So, Shrikant, I think you think quite a lot about peer relationships and that sort of thing. So, yeah, sorry, I unmute Shrikant, and I know he'll have
Peters is
useful
unable to
things.
unmute.
Yeah, I think he hasn't got that co-host status. You should be able to. Yeah, that's it. Great. Yeah, Shrikant, I'd love to hear your thoughts on this because we've spoken about it before.
Yes. No, thanks very much. What we're finding more and more, and it's quite a scary thing, and it was mentioned in the background to this, from a very young age, even undergraduate, we're seeing medical students and early career doctors having to bolster their CVs to apply for posts, 200 applicants for one post. And a lot of the previous gaps we would see, things that would differentiate people in interviews, is the ability and the experience of research, because it wasn't something you'd come across very often the last 10 years or so. Now you see a lot more people, and the question is around how do you get access to those kinds of opportunities? You've heard it from Dr. Farina. You have to make them yourself. You have to be a bit of a maverick, and it starts at the basis of being a clinician. Clinicians are there, and for better or worse, to solve problems, establish disease that we are responsible for diagnosing and managing and following up. And a lot of the world of research is around finding problems in current management, problems in health systems, problems in the facility that you're based at. They can be target times not being met. They can be failed audits. They can be morbidity and mortality meetings. They can be patient safety incidents. The fact is there's data everywhere, right? It might not be collected. It might not be analyzed. It might be actively ignored by management structures conveniently. But interns, community service doctors, medical officers, junior doctors are the ones that are best placed to identify problems in the system. But really, you have to take the next step to identify, and these are things we would ask in interviews as well. Okay, well, you found a problem. How are you going to investigate it? Okay, what's your approach for looking at the literature? Who have you identified as mentors in a field? How would you go about structuring your research? These are all things you can think about on your own steam. But even in terms of research and ethics protocols, we've got our traditional academic platforms to push through ethics proposals. But the South African Medical Association now has its own research ethics committee. Private hospitals have their own research ethics committees. There are avenues available, even if you're not associated with a formal academic institution. And wherever you work, there's a chain of command. There are senior clinicians, there's senior managers, there's people sitting with data that need to be converted into reports. There are clinical governance and clinical audit opportunities available for everyone. And I would say, please take up those opportunities in your rotations as interns, as ComServes, to analyze some of that data, publish a report, write an editorial. There are always options available.
Thank you, Dr. Peters and Dr. Farina and Dr. Biccard.
Sorry, can I add just one little thing, because I think it's quite a powerful mechanism that I've used. I would suggest that you start off with trying to publish a case report. You see something abnormal. The latest one that I've got is a incredibly high insulin glucose infusion for calcium channel blocker. And we went beyond what is generally recommended in the literature, but we managed to save the life. And it really interested this one junior doctor. And he went to all the effort to do all the work of a case report. And it's turning out into a thing where I know we will end up with more meaningful research coming out of this guy. So if you're trying to break the ice and do something, find something that fascinates you, do a little case report. It gets you into publishing, it gets you into talking to a senior person and doing a literature review as you have to find out the facts behind what happened in the case. Thanks very much.
Thank you, Prof. Farina. The next thing we want to talk about is, I guess we already touched on it a little bit, but it's about how young researchers can become more involved in collaborative research. For Dr. Mvo, what are your thoughts?
Okay, good evening again. I think, yes, most of the points of advice I had on this issue have already been covered, but I would still like to emphasize just a few things using my own experience, because I actually had the privilege of starting with public health research before I became a clinician. I think that was really the best environment, because whenever I look at the clinical setting, I just do not see clinicians prioritizing research. And it really takes a student who's really passionate about research to be proactive and try to find out who's doing research on what. Like, even though I came with research experience already in medical school, I never knew which clinician, in different departments were doing which research. And I think that's the problem with most of the doctors that are still undergraduate or are undergoing training, even at the level of registrarship, because they just become involved with just their MEd projects. But by that time, when they have to be doing MEd projects, they've never really had anyone, who helped them to get interested in research. So the MEd becomes just a burden, a punishment, a frustration, because, it's something that they are forced to do. Unlike, for other doctors whose primary interest is research, which was my case. So I think what's important, even in the clinical setting now for medical doctors, in order to be part of a collaborative team, is to actually decide on the area of research that you're interested in, because then you can attach yourself to that particular, specialist. Let's say you're interested in infectious disease, or you're interested in women's health or reproductive health, or you're interested in nutrition. So you've got to start by developing an area, a topic, like, a discipline that you're interested in, because there's nothing as frustrating as doing research and something you're not passionate about. That becomes another, like burden or punishment. And then you have to develop good communication skills, written and verbal. So whilst you're still developing interest, of course, you're going to be reading journal articles, you're going to be trying to find out, who's doing research in your area of interest, and then you approach them, you come up with questions, you actually find out what projects they are busy with. I've seen quite a few undergrad medical students who use their mid-year vacation and even December vacation, which are a bit long, to volunteer to participate in field work as well. That also gives you exposure to the conduct, like how research is conducted. And then you can decide during that time really what is, what's your interest around research. And then what's also nice now is like this information technology that has grown, that you can also have access to conferences, you can attend conferences virtually, which is something that's also a limitation when you're a medical student, because there are no opportunities to go for conferences, which is they go to conferences, attend webinars, but now, because some of these conferences are hybrid, they have hybrid programs, so you can actually attend conferences, because that also gives you exposure and, to see people that are really passionate about research, how they go about, what their research, what are their research findings, and some who are presenting intervention studies. how were their research results, how were they implemented. So it really takes you being proactive. And as it's been discussed by other panelists, you know, like finding a mentor, I think is very, very crucial. And that relationship cannot be forced, but once established, it has to be someone who is going to be consistent, who understands their role as a mentor. That mentor, you know, the mentoring role, even if sometimes someone cannot be a jack of all trades, but it still is a good support system to have someone you are accountable to, whom you can, you know, have regular meetings with, and they have to be formalized. There's nothing that's called like unstructured mentorship that can work within a research field. So I think that's like really the role of seniors that are involved in research to really be intentional about mentoring young or aspiring researchers. And the last thing, which also has been mentioned, is just about being patient and being persistent as well, you know, like those emails, those reminders, you know, and just understanding in general, you know, the ethics of research, you know, and when we're talking about collaborative research as well, but even if it's just, in fact, it's always collaborative, even if it's local, even if it involves scientists from other countries. But the key thing is that really when you're talking research, you deal with personalities. So you have to have a way of dealing with interpersonal conflicts because people have their own personalities, characters. When someone is not in the mood to read your manuscript, to review it, you're gonna be waiting. They're sitting on it for 3 weeks and you wanted to submit it last week. So you have to have an approach of just, you know, being able to deal with those different personalities because they will be very, very diverse in a collaborative team. So I think that's all I can say for now, but yeah, it takes you really being proactive at the end and knowing what you want.
Thank you, Dr.
Thanks.
Thanks for reminding us to be more proactive and also not be afraid to take the first step towards pursuing a career in research. I want to move on to Dr. Peters. Everyone sort of has a different pathway into research or into their career. What decisions that you made would you say were pivotal in shaping your research path in public health, and how would you encourage young researchers to do the same if they wanted to? Can we unmute? Let's see.
Great, thank you. Thanks for the question. So I always struggle with this one, but fair enough. Public health does have research as one of its major competencies, so much so that if you're a registrar in public health, you will not be allowed to write your final fellowship exams until you have demonstrated that you've passed your master's in medicine thesis. So that's as well as the fact that we have a separate short report that needs to be published during your registrar time. So research does form a large component of public health. But I think the assumption that a lot of doctors make is that public health equals research. There's a lot of people who do fantastic research in public health that are not public health medical specialists, right? Your MPHs and your PhDs. And really what shapes a lot of doctors, not just people who end up in public health as the specialty, what shapes people's research paths are what they've found in the clinical workspace. And so within any discipline of medicine, if you're interested in specializing, any clinical or non-clinical branch of medicine, you do need to acquire the skills of research, and you can outsource a fair amount as a registrar. But if you're looking to be a consultant, you need to be able to publish a mini thesis. You need to understand a little bit about research protocols and how to generate knowledge and truth that can stand up and against bias and confounding and those kinds of things. But really within public health, public health really gives you access to broad scope in terms of people looking at big problems, high-level problems within districts at the level of facility management, at the level of national data sets, and really where we are looking to apply our trade as public health specialists is in big data and citizen-generated data as well. And what you can do when you start combining big complex data sets together with a layer of artificial intelligence, and how you can then leverage that for patients and for policymakers and clinicians. But the reason why, at the heart of it, the reason why I got into public health was a simple clinical problem. Just not being able to triage patients effectively in a peri-urban facility in Durban Metro, right? And for me, it was just about, how long does it take us to see patients? What are the resources we have to triage in a busy emergency center? Are we making full use of that? And really from there, moving on into public health and quality of care, applied waiting time surveys from emergency centers to the emergency theaters, back to emergency centers, which I manage now currently. And it's really that ability, what was pivotal in shaping my path into public health was the ability to link back to the clinical space, and to inhabit both the role of a researcher as well as a clinical support person, because our role in providing support to clinicians who can see their clinical practice transform if knowledge translation activities occur is fantastic. So where we are currently, also linking back to barriers and how to enable a greater sort of a democratization of research, is to get to the point where as official managers of data sets for the province, for the National Department of Health, for facilities, we want to get to the point where those official data sets are recognized as registries under health research ethics committees. Because once we do that, we can then link unique patient identifiers on our systems. So the National Department of Health is rolling out a unique patient identifier based on ID numbers and refugee numbers. In the Western Cape, we've had a unique patient identifier system going back to the 1990s, which is why for some of you that have worked here, you'll notice that there is a single patient folder number across the province that links across facilities and can link you from a hospital run by the province to a clinic run by the city. And it means that we can now start constructing electronic health records. Where it gets very, very interesting in public health, where you break free from the constraints of a single facility, is that we can then link these data sets by patient demographics, age, gender, citizen status. We can link diagnostic and procedure codes that are coming from our facilities. We can link mortality rates. We can link death data coming from home affairs. And once you start linking those with these rich clinical silos that are generally kept in research-specific databases like REDCap, if we get those data sharing agreements in place, we can really create health intelligence networks of managers and researchers and junior clinicians who, even though they have access to a small portion of the data set, it gives a very deep understanding of, what is the supply and demand for healthcare? What is the quality of our care that we're providing? What is the 30-day mortality rate for medicine and surgery in a tertiary institute? Because we've linked all of the surrounding facilities and home affairs, which is collecting people that pass away at home. And so really what we'd like to do is enable a system of operational research where the work that you do as an intern feeds into a greater system of clinical governance. If it's simply, infection prevention and control, how you put an IV line in and whether it's done under aseptic technique, we should be able to link your practice as an intern to whether or not a patient develops drip site sepsis 1 week later or 3 months down the line after you've finished your rotation. Because if we're able to link people's lived clinical experience on the wards or in theaters with big level data sets of how their practice is informing big level clinical governance and quality of care in a hospital, we can then have people who can publish work that is real, that makes a difference, that is not difficult to do because there's already data registries and ethics approval in place. So we really need to have a system of governance for research, and that's what we're doing at Grootskier. And something we're looking at rolling out with other facilities is to have ongoing operational database registries that enable clinicians to work hand in hand with researchers, and also enable junior researchers to get into research at a much earlier part of their career and see it inform how their clinical practice changes on the ground.
Thank you so much, Dr. Peters, for that question and the answer as well. I think you raised quite a few points about data sharing and working towards a national data registry for healthcare providers. When can we expect to see this come into play nationally?
So you'll see a lot of piecemeal changes happening, and I have contacts with my colleague cohort from when I was in medical school, and so I get to hear about things. So the provinces, the Western Cape does have a provincial unique patient identifier. The National Department has rolled out a system called HPRS. KwaZulu-Natal has the e-health system, which is a sort of a behemoth system that they're trying to roll out in totality. And ultimately, we're trying to link the different data sets. So the Western Cape has an older system, but is linking to the National Identity Document System. And you can see the importance of that. I mean, our patients are South African patients, or they cross borders all the time, and we need to get to a point of having a national database and a national unique patient identifier. But really, what's going to help the system is if people in facilities take up, we need mavericks. We need people who are interested in having data registries in their own facilities to start working on establishing these registries with clinicians and managers at those facilities, and then pass them on to the next group of interns and community service doctors that come along. Because really the way the system will grow properly is organically, a registry at this facility and that facility that can then standardize the data that they're collecting and then do comparative research across. That's what then becomes powerful, and then we can standardize how we collect data, what the definitions are for your research terms. And ultimately, you'd want that to be recognized by ethics committees locally and then nationally, and then you want managers to make decisions based on the data. I mean, that's the fantasy that clinicians live in. Not fantasy, but that's really what clinicians want. They want to publish data that makes a meaningful impact to patients' lives. And yeah, I think we really need to work on having clinicians and managers and researchers in the same room, designing systems that can both manage operational research and clinical governance and business units, as well as provide outlets for formal research. They should do both at the same time. Thanks.
Excellent. I think Dr. Farina has a point to raise.
Yeah, just a quick thing. So first of all, those of you who are on KZN Health and eHealth, Shrikant, don't fall with the propaganda. There's no working system whatsoever.
No, I know.
Then, secondly, what is good though, compared to when I started out, is there are well-established ethical rules for getting registries registered, so that you are allowed to keep them and have patient data accessible. And then exactly how you publish from those registries. And you have to notify the ethics committee that your registry is being used for research. And then you have to show exactly how it's used. But at least you've got over the hurdle. Why have you been collecting this data before you seek ethics authorization for your research. Basically, you get one small class approval for keeping a database, and then you get another approval for what you want to publish. And that second approval is now much easier than it used to be. Thank you.
Thanks so much, Dr. Farina. I guess open question to all the panelists, but also specifically to Dr. Peters is, we've touched on, of course, the importance of clinical governance. And what advice would you have for, let's say, an intern, a medical student, or especially community service doctors that are working in more remote areas, that are wanting to start clinical governance projects or internal audits, but may not necessarily have the support of clinical managers on site? How can they overcome that and actually start leading change on the ground?
I think it's, yeah. What's really, really great, if an intern were to come to me and ask me, what are the problems you face? It's kind of the opposite for clinicians. If you come to them with a problem and this is the idea that you have to solve it, that's great and we can work with you. But as a manager who generally sits with a dashboard of people asking me to solve their problems for them, and generally it resolves around budget and staff, which nobody can solve at this point in time. If you come to me with a possible solution, or no, if you come to me and ask me what are the problems that I have that need to be fixed, it's great to have data, but someone to analyze it and do a deep dive on a certain problem, generally managers don't have that luxury, or senior clinicians as well. So having something like assessing an M&M, presenting at M&M, looking at doing a clinical audit from a problem that's been identified, that sort of ticks a lot of boxes for managers and senior clinicians. If you've noticed a problem where patients are, undergoing morbidity and mortality that they shouldn't be, or to the point where you've seen that a hospital has failed on a certain audit standard. All hospitals are being audited on an annual basis. You see it in the Office of Health Standards Compliance documentation. And if we don't have evidence of clinical audits being done, we will fail those. So if you've got something that can be placed on the manager's agenda and say, look, this is a clinical audit that's been done, and you've also improved patient care, that's fantastic, and it's something you can add on your CV, and you can write you can take one of those and write a case report, as Dr. Farina has said. I think it's far more valuable than a manager going and saying, okay, well, I'd like to just do this clinical audit just to tick a box on the Office of Health Standards Compliance, but it might not actually change anything, and it might not be of any relevance. But really look at clinical governance, look at clinical audit, which is more a project-based type, look at a specific indicator that you can analyze over your time, or 6-month rotation within ComServe, or 3 months in internship, and really look at something, do a deep dive, go through a folder audit, look at waiting times, look at infection rates, staff attitudes, and patient complaints and compliments. There's lots of things that you can analyze for a manager or a senior. That would assist them greatly. Yeah.
Thanks so much, Dr. Peters. I'll hand over to Zane now.
Thanks, all the speakers. Just one final question from us. If you were to if you wanted the junior doctors and researchers to take one thing from this whole discussion, what would it be? Should we start with Prof. Biccard?
Yeah, thanks, Steve. I think the one thing is research is actually really cool. You can do really great stuff. There's massive opportunity in our environment. I think you guys have got a huge head start with your group. I think you need to really realize the power you got, enjoy it. It should just be part of what we do in our normal clinical lives. So well done.
Thank you, Prof. Prof. Farina?
So I would suggest to you guys, don't do research for research's sake. In other words, you've got this here, don't just go off and do exactly what, just get something done. But identify what interests you, and then try and work that into your goal to have a research portfolio in your CV. Thanks very much.
Thank you, Dr. Farina. Dr. Mvo?
Okay, so my closing remarks, I think I'm preaching to myself, who is a converted, I'm just sold out to research. But I think really, for me, it was just so exciting to see, medical trainee initiated, research, this initiative itself, because when I got into research, it was not popular at that time. All my friends thought I was crazy when I finished my B degree. It was like, I just want to explore research, and at that time, of course, I wasn't a medic. I was a social scientist, but I knew I was going into medicine, so I wanted to learn anything public health, you know, and I started with an easy topic of malnutrition because I had seen it was a problem. So my parting words would be this, you know, you are even in a better position because you have this clinical background. And these days, really, you cannot practice medicine without evidence. So research is very, very important. So you don't need convincing about your step of getting involved. Only if you were to be proactive, you will really enjoy research.
Thank you, Dr. Mvo. And lastly, Dr. Peters.
Sure. No, I think we've covered those. We've covered these, but just to emphasize, be proactive. You know, it is something that comes from you. It's something that you've identified in the system that you'd like to change, that you would like to investigate further. And trust your instincts. If you've seen something, you're a data point in the system, right? When the system completely collapses, clinicians then become silent and accept what is happening. Research is an opportunity to make big changes at scale for lots of patients, and it's an extension of your identity as a clinician. Leverage your networks. You've got a fantastic network of nationally representative junior clinicians. That's fantastic. And then just remember, you know, as intimidating as research might be, you guys have a lot of tools. I mean, I can see what artificial intelligence can do and how they auto-generate a lot of things. Obviously, you know, keep a handle on it and make sure that you can claim that you have created a lot of the content you're generating. But even in discussions with ethics committees, things that you submit to them, it's a discussion. You know, you send in documents, you get feedback, you will be given. So don't let that be a stumbling block for you starting. Jump in and try. Thanks.
Thank you, Dr. Peters. And I just want to close off this webinar here. I just want to thank all the panelists for giving up your time and sharing your knowledge and your experience and your advice for junior doctors and junior researchers and juniors everywhere, and encouraging us to be more proactive and being more involved in research. Thanks to the team at SAMTRA that put this whole thing together. And also thanks to everyone who joined this evening. I just want to let you know that we have a website and a LinkedIn and social media channels. So please follow us, check out our website. We also have other resources and blogs on there as well. And lastly, to look out for our next webinar coming soon. Thank you very much, everybody. Have a good evening.
Thanks once again for the invite and the opportunity to speak to you guys. Thank you.
Thanks and bye.